So before I begin, I just want to mention that this is somewhat a light topic in terms of how deep and complex we could go into. I thought this level of complexity would be most appropriate for us as medical students, and this is meant to be an easy talk, easy listen kind of presentation. So please bear with me. I actually merged two papers together to create a bridge between the acute and long-term consequences of concussion and how rehabilitation modalities play a role across that spectrum. So today I'll be talking about from concussion to CTE, the PM&R role in managing and preventing neurodegeneration in contact sports. So as background and overview of what we're going to talk about, and before we actually dive into the papers, I want to show all of you this diagram here. Here's a pyramid which shows how common concussions really are. We see around 1.1 million ER visits and hundreds of thousands of hospitalizations every year, but the largest group is actually those who never seek care at all. So the real number is likely much, much higher. This helps explain why concussion management and long-term rehabilitation are so important, which leads to our discussion on the mechanisms and recovery focus. So let's start with a discussion on concussion in sports specifically. So every year, between 1.6 to 3.8 million sports-related concussions occur in the US, and among all contact sports, American football is the leading cause. The main mechanism involves both linear and rotation acceleration of the brain inside the skull. This causes axonal shearing, ionic flux, and excitotoxicity, basically a temporary metabolic crisis where the brain cannot function normally. Clinically, we can think of it as a spectrum, starting from a single concussion or mild traumatic brain injury to post-concussive syndrome if symptoms persist, and with repetitive head impacts over the time, it can progress to chronic traumatic encephalopathy or CTE. And from a rehabilitation standpoint, PM&R focuses not just on resolving the symptoms, but on helping patients achieve full functional recovery and improving their long-term quality of life. So to set the stage, I want to briefly show how concussions and long-term brain injury are connected. You might recognize this image on your left-hand side. It's from the movie Concussion. This film is actually based on a true story of Dr. Benedamalu, the neuropathologist who first discovered chronic traumatic encephalopathy or CTE in former NFL players. On your right-hand side, you can see brain slices showing the progression of CTE. In stage 1 and 2, there are only a few small areas of damage, often near the blood vessels. But by stage 3 and 4, there's much more widespread degeneration, especially in areas controlling memory, judgment, and emotion. What's really striking is how these changes happen over years of repetitive head impacts, not just from one big hit, but from thousands of smaller ones. And that's where concussion management and prevention becomes so critical. So now we move on to our first paper from Dr. Silverberg from 2020. So the main objective of this paper was to bring together recent concussion and mild traumatic brain injury guidelines into one unified rehab-focused framework, something that PM&R physicians can actually apply in practice. It's a narrative synthesis, basically an expert consensus that combines multiple guidelines like those from the CDC, the VA, and the Berlin Consensus. It covers everything from acute management, risk stratification, functional rehabilitation domains, to return to activity and return to sport protocols, and it's relevant for athletes, civilians, and even military populations. So I want to show you some of the key clinical frameworks from this paper. The paper summarized the initial management and rehab framework, basically what we should do right after a concussion or what we should do after we speculate the first concussion event. First, in the initial evaluation, we always perform a focused neuro exam and check for any red flags. Things like loss of consciousness over 30 minutes, focal deficits, or worsening GCS score. We also ask about prior concussions or psychiatric history, since those increase the risk for a slower recovery. CT and MRI is not routine, only if the patient meets the Canadian CT head rule or the New Orleans criteria. Next is education and reassurance. Just by explaining that most people recover from concussion in 1 to 2 weeks and what to expect actually reduces anxiety and chronic symptoms. Then rest and return to activity. We now know that complete rest for more than 48 hours actually delays recovery. Instead, what we do is we encourage light symptom limited aerobic activity within 24 to 48 hours once tolerated, things like walking or gentle cycling. And finally, you can see the rehab domains table at the bottom. These are the key functional areas we focus on in PM&R. So first of all, vestibular and oculomotor. We focus on balance, gaze stability, especially using VOR training exercises. Neuromotor and gait, retraining dynamic control and reaction speed. Cognitive domain, we improve processing speed, attention, and dual tasking. Emotional domain, we address mood, anxiety, and sleep hygiene. So this framework shifts concussion care from passive rest to active targeted rehabilitation care, which is very much in line with the PM&R approach. So as we continue with some of the key clinical frameworks from this paper, we also have something called return to sport, return to play progression. The key idea is that this progression is criteria based, not time based. That means we only move forward when the athlete is symptom free, and we typically advance every 24 hours if no symptoms return. So we have 6 stages in total, and stage one, symptom limited. This is the initial rest phase. The athlete should focus on basic daily activities or ADLs with plenty of rest. The PM&R focus here is on education and reassurance, helping the patient understand that the symptoms are temporary and guiding them through a safe recovery. Now we move on to the second stage, which is light aerobic. We add very light activity like walking or stationary cycling just to increase heart rate a little bit. We carefully monitor both heart rate and symptoms to make sure that they don't worsen. And stage three, which is sport specific non contact. At this stage, the athlete can start doing sport specific drills like footwork or position work, but still no contact. What we focus here is neuromotor retraining, helping rebuild the coordination, balance, and movement control. And then we move on to the next stage, stage four, non-contact training drills. We can increase the intensity and add more complex movements such as cutting or passing. This is also the time to perform the vestibular and ocular screening to make sure that balance and visual trackings are very normal. Stage five, full contact practice. Here, the athlete can participate in full practice under supervision. Before we move on to the next stage, we perform functional testing to make sure that they're fully cleared for contact. Stage six is return to competition. The athlete returns to full gameplay or competition. Even at the stage, there's ongoing monitoring to ensure no symptoms return. If symptoms last longer than 4 weeks, we use a multidisciplinary rehab approach, including vestibular therapy, oculomotor training, CBT, and graded exertion. But if symptoms persist, or if there are comorbidities or a high risk profile, the patient should be referred for further specialized care. So to wrap up, here are the main take-home points from this paper. This paper really highlights the PM&R central role in concussion recovery, not just treating the symptoms, but guiding safe, structured rehabilitation. Evidence supports early, carefully monitored exercise and domain-specific therapy rather than prolonged rest for over 48 hours. And for persistent and complex cases, interdisciplinary coordination is key between PM&R, physical therapy, occupational therapy, and psychology. The focus should always be on objective recovery, things like balance and reaction time testing, while also setting realistic expectations for athletes and coaches. And finally, a criteria-based return to play rather than time-based approach helps prevent premature return to play or RTP, which may lower the risk of long-term neurodegenerative risk. So even when concussions are managed properly, athletes, especially in contact sports like American football, may still experience hundreds of subconcussive hits every year. These are impacts that don't cause obvious symptoms of concussion but still affect the brain. When another brain injury happens before full recovery, the brain enters what's called a neurometabolic vulnerability. It's more sensitive to damage. Over time, this repeated stress leads to chronic neuroinflammation and tau protein buildup, or tauopathy, which are key features linked to long-term decline and possibly chronic traumatic encephalopathy, or CTE, later in life. So the question becomes, can repeated subconcussive hits, even without a diagnosed concussion, set the stage for CTE later in life? This is something we could also think about. So now we move on to the second paper from Dr. Ann McKee from Boston University from 2016. So this paper summarizes a huge data set from the Boston University CT Center, starting from Dr. Bennett Amalu's 2005 dataset to McKee's expanded data in 2013. Um, the main objective was to review how repetitive head impacts, both concussive and subconcussive, contribute to long-term neurodegeneration and CTE later in life. The study focused mainly on contact sport athletes like football players, boxers, hockey players, and even military veterans. They analyzed over 100 autopsied brains using detailed immunostaining for tau protein to map lesion distribution. Then they connected those findings with medical and behavioral histories and even supported them with animal models showing similar tau buildup after repetitive mild traumatic brain injuries. So this paper essentially bridges pathology, clinical evidence, and experimental work to explain how repetitive head trauma can lead to chronic brain disease or CTE later in life. So here we're looking at how CTE progresses both clinically and pathologically. First, there is usually a very, very long latency period, which is approximately 15 years after repetitive head trauma before symptoms appear, which is why prevention is so important, critical from rehabilitation standpoint. Another thing that we need to focus on here is that the diagnosis can only be made post-mortem, since we need to see the characteristic brain changes under a microscope. And the only thing we can do when the patient's alive is just speculate that the patient has the signs and symptoms of CTE by his cognitive difficulties, mood dysfunction, and behavioral symptoms that the patient's showing. Mechanically, each head impact stretches the axons, leading to ionic imbalances, metabolic disruption, and inflammation. The most important hallmark lesion of CTE is the accumulation of hyperphosphorylated tau protein around the small blood vessels, especially deep in the cortical sulci. Over time, this pathology spreads to the other parts of the brain, affecting emotion, judgment, and an executive function. The beta amyloid plaques can also appear, and when they do, the disease tends to progress faster and cause more severe symptoms. Clinically, we see a gradual evolution from being asymptomatic or just having mild headaches in stage 1 to mood changes in stage 2, cognitive decline and impulsivity in stage 3, and finally dementia and Parkinsonian signs in stage 4. When we talk about the risk for CTE, it's really a combination of exposure and recovery factors. The biggest one is the number of concussions and subconcussive hits. The more exposures, the greater the cumulative brain stress. Age at first exposure also matters. Starting contact sports before the age of 12 has been linked to a higher lifetime risk. Duration of play and genetic factors could also play a role in contributing to CTE development later in life. Another key risk is inadequate recovery. When athletes return to play too early before their brain has fully healed, and comorbidities like depression, substance use, or poor sleep can also worsen outcomes and delay recovery. So when we look at those overall continuum, it goes from a single concussion to repetitive head impacts and ultimately, in some cases, to CTE. And this is where PM&R really fits in the middle. Through early rehabilitation and a criteria-based return to play approach, we can reduce cumulative brain stress and possibly lower the long-term risk of CTE. So currently, there's no disease-modifying treatment for CTE, meaning we can't reverse or stop its progression. Management is mainly supportive and only about the symptoms the patients are showing. This includes cognitive rehabilitation to help with memory and attention, behavioral therapy or psychiatric support for mood and impulsivity, occupational therapy to address executive dysfunction, and physical therapy to improve balance and manage Parkinsonian features. In research, there's actually a growing interest in therapies targeting tau aggregation, as well as neuroprotective agents, aerobic neuroplasticity training, and anti-inflammatory drugs. But all of these are still experimental, but still something we could all look into. And this brings us to a key discussion point. If CTE has no cure, is retirement the only treatment option for athletes at risk? That's something that we could all think about. Here, I want to show you how awareness of concussion risk and the long-term exposure of repetitive head trauma has begun to change the culture of contact sports. On the left is Chris Borland, a former San Francisco 49ers linebacker who made headlines when he retired super early, right after his first rookie season, because of concerns about long-term effects of repetitive head trauma and maybe developing CTE later in life. His decision sparked major conversations in the league around safety, prevention, and player health. On your right, you can see players wearing something called Guardian caps, which is a type of soft shell helmet cover designed to reduce impact forces during practices. This is one example of how technology is being used to lower subconcussive impacts. Alongside the helmet innovation, we're also seeing changes in contact rules and return to play rehabilitation protocols, which are all aiming to reduce cumulative brain stress and protect athletes over their careers. To wrap up, the key message from both papers is that concussion is in fact a functional injury, and recovery has to be criteria based, not time based. That's the most important thing, and also multidisciplinary. Repeated subclinical head impacts build up over time and can increase the risk for long term neurodegeneration or CTE. This is where physiatrists play a central role, guiding early rehabilitation, managing safe return to activity, educating athletes about cumulative risk, and helping develop neuroprotective interventions. And the biggest takeaway, I think, from my presentation today is that rehabilitation isn't just about returning athletes to play, it's about returning them to life in a very safe way. So here are my references, and thank you, everyone.